Now let me discuss a stepwise management of insomnia in older adults. So the bottom line, based on what we had already discussed in this module so far, that the American Academy of Sleep Medicine gives its strongest recommendation for using CBTI for chronic insomnia in older adults. There is no sufficient statistically significant data to support the long-term use, safety, and efficacy of any medication that we had mentioned, especially in older adults, due to the impact on their sleep architecture and how aging impacts on the pharmacokinetics and the pharmacodynamics of these drugs. That being said, we should learn ourselves and teach our patients that primary prevention is key. Establishing healthy sleep habits and maintaining them into our late life years is key to avoid or prevent or minimize the problems that commonly occur in older adults with their sleep. And by the way, this is not the son of Poseidon. So for the management of insomnia in older adults, here's a suggested flowchart of management. 1 is to obtain a thorough history of present illness. 2 is to review and identify predisposing, precipitating, and perpetuating factors. Obtain a medical and psychiatric medication history. Start by treating any underlying causes. Again, don't forget the pain. Offer non-pharmacological treatment first. If failed, then you can go for pharmacological treatments. And then address any comorbid sleep disorders. And then monitor response and reevaluate the treatment plan every now and then. So, pills might be easier, but drills are definitely much safer. Okay, so let's dig deeper into pharmacological options for insomnia. For example, if we have a client who presents with prominent depressive symptoms, we should try something like trazodone or mirtazapine, and if failed, we could try doxepine or amitriptyline at low doses. If the patient presents with prominent psychotic symptoms, we might consider quetiapine at a low dose, somewhere between 25 and 100 milligrams. If that fails, we can try risperidone at a low dose, olanzapine, or even clozapine if they have resistant psychosis. For those with prominent anxiety symptoms, we can try trazodone or mirtazapine at low doses, and if failed, we can use pregabalin or gabapentin. So what if they don't have any of those symptoms and they just present with primary insomnia? In that case, we should try melatonin or amiltione. If that fails, we can try DORAs, which we had discussed earlier, or antihistamines. And if all these options fail, then we might resort to the Z drugs. And if the Z drugs fail, that's when we try to give a short course of benzodiazepines. Just a quick note, for antihistamines, it's better to use fexofenadine and cetirizine, which are the least anticholinergic, to avoid as much as we can cognitive impairment in older adults. And in those with Alzheimer's disease and related dementias, they might actually benefit from adding memantine. There are some reports that it can help with insomnia.